So good evening, everyone. My name is Amy Button. I'm the CEO of Crossroads for Hope, and I'm honored to be your moderator this evening. I want to thank you for joining us. This is Crossroads for Hope's first post-ASCO roundtable discussion, and we hope that this is the beginning of a series of events that we can host, including future journal clubs, focusing on research and convening stakeholders across healthcare to talk about new discoveries and new innovations and their impact on patients and their families. I just want to cover a few housekeeping items just for everyone here. So please turn off your cell phones if you can. If you need to use the restroom, there is one in for the people here in the kitchen. And just exits, it seems obvious this is an exit, but you can also get out the door you entered. We are broadcasting and recording. We have folks on Zoom. We are mic'd, not for you, but we're mic'd for the people on Zoom. So if you cannot hear us, just raise your hand. I think we talk all pretty loud, so it shouldn't be an issue. We will be doing a Q&A, and for those on Zoom, you'll be able to put your questions in the chat. And at your tables, you have packets about this event, and I have also included some information about Crossroads for Hope, our services, as well as some information on supportive cancer care that we're involved in advocating for nationally through the Together for Supportive Cancer Care Coalition. I just want to mention before we get started, this is Crossroads for Hope's 25th year of serving patients in town. And we have grown. We have provided supportive cancer care services at no charge to over 35,000 people across New Jersey, nationwide, and more recently internationally. And we do that thanks to the donors and supporters of our mission. But we're here to provide professional support, information, resources, the fundamental support that patients need between appointments with their doctors, and live as they live through and beyond cancer. So we're proud to serve that mission. Tonight, we're going to be discussing key takeaways from ASCO's annual meeting. The theme this year was the science of practice and translation, improving cancer outcomes worldwide. They challenged us to ask not only what scientific breakthroughs are possible, but how do we ensure that those advances translate into better outcomes and better experiences for people who are diagnosed with cancer, regardless of where they live or where they receive their care. I'd like to introduce our panel. Tonight, we have a distinguished panel. Whose experiences and expertise really span the gamut of healthcare, from clinical care to research. And so we're so pleased to have you all here. And I'm going to start by introducing Carolyn Clark, who's a published researcher. She's been a clinician. She is the Director of Guidelines and Quality at the Oncology Nursing Society, professional home to more than 35,000 oncology nurses nationwide. She leads the development of evidence-based guidelines and quality initiatives that improve symptom management and patient care across the continuum of cancer care. So we're so glad to have you, Carolyn. And we're glad to partner with ONS nationally as well. Dr. Patel, who's also on our medical advisory board, is the medical director of RWJ Barnabas Health Steeplechase Cancer Center and a board-certified medical oncologist specializing in thoracic, gastrointestinal, and hematological cancers. He has championed innovations that expand access to advanced therapies, clinical trials, and equitable cancer care in community settings. He's an advocate for supportive cancer care, and we're so glad to have him here this evening.
Thank you.
And on Zoom, we have Dr. Toplinsky, who's the head of breast and gynecological medical oncology at Valley Mount Sinai Comprehensive Cancer Care. I think there's cancer care setting, and a clinical assistant professor at the Icahn School of Medicine at Mount Sinai. Her work focuses on young women with breast cancer survivorship and using education and advocacy to empower patients throughout their cancer journey. So I want to welcome you all and all of you who are on Zoom with us this evening. So we're going to start with the meat of this conversation, which is really talking about the breakthroughs and innovations that were discussed at ASCO. I want to pose this question to each of the panelists. So based on your area of expertise, what scientific advances presented at ASCO do you believe will have the greatest impact on patients and the standard of care over the next 12 months? And I'd like to start with Dr. Patel.
So I think there were, first of all, thank you for having me.
Oh.
And thank you for the great question. I think it was one of the great meetings that I have been to. I go to ASCO every year, and fortunately, every year now we see a breakthrough medication where there is a standing ovation. And I think, as you will see, that's something that will really come into practice. And there's been a lot of news around it. It's a new pancreatic medication. So based on Rasulo trial, there is a new pan-RAS inhibitor for pancreatic cancer. This is very big in terms of practice changing, because as you guys know, pancreatic cancer is very aggressive cancer. For many years, I think 20 plus years, they have tried many different combination of treatment, very new novel agents. Everything has failed to show survival benefit, but now we have something that is targetable and showing a survival benefit, PFS benefit for our patients. So I think that is definitely one of the number one abstract that I will say is it is a practice changing, and there will be a lot of news around it as soon as it's available. I think patients are already aware of it, and they've been asking for this new medication. So I think that would be the first practice changing in next 12 months.
And I'm just curious, I think I had read somewhere that it actually, the science behind that may work on other tumors.
So I think we are very excited. This is just the beginning. It is a pan-RAS inhibitor, so it works for multiple different RAS inhibition, and that will colon cancer, lung cancer. I think those are other cancers that it will also work on. So this is just the beginning, and I think we will also like to see if the combination works better. So in the future, we'll be able to get more and more patients treated across all different kind of cancers. So I think we are moving really towards that precision medicine. That is our goal, right? I think we are want to make sure that every patient has their own different molecular precision medicine, more targeted toward their cancer instead of having the blanket treatment.
I know that received a standing ovation at ASCO, and rightfully so. Were there any other papers that you had seen that you would want to share tonight?
I think there was many different abstract that sharing the circulating tumor DNA, how to utilize that in our clinical practices. Circulating tumor DNA is basically more of a liquid biopsy. So basically you're doing a blood work that isolate the tumor DNA from the blood and does the molecular typing on those circulating tumor DNA. Until now, we knew that it has a prognostic indications. So positive circulating tumor DNA has poor PFS or survival benefit and early recurrence. So we knew the prognostic indication, but there were a lot of abstract that helped us now how to incorporate that into like a treatment paradigm in our daily life. And I think that's very important. We know ctDNA is very helpful, but what to do with it, we didn't know. And I think a lot of the abstract has shed some light in terms of how to incorporate that into the treatment practices. So I think that's another interesting portion.
So Carolyn, what are your thoughts?
I think, coming at this from the nursing perspective is what do things like that mean to the patient? And so I would let Dr. Toplinski talk about the OPTIMA trial for breast cancer, but I would mention that several of the studies were about de-escalation of treatment, like who can safely be de-escalated in radiation doses, who can safely not receive treatment that might have been receiving treatment before. And to me, that's amazing, right? Because you're saving the patient from a symptom burden that they might not need, and their clinical outcomes are not compromised. So that's definitely the quality of life, piece of it. And I think then also, all the oral targeted therapies, that allows a patient to be home. And what I heard at ASCO, NCCN, ONS was all about time toxicity. and the burden to the patient in traveling to appointments and getting someone to bring them, in sitting in infusion chairs in multiple clinic visits. And I think it's kind of a now, maybe previously overlooked burden, but now really coming to light that what this saves the patient and what it means to them and their family is really important. And I think from our end as the clinical team is now they're at home, and how do we stay connected and know they're getting back to us about symptom monitoring and still like maintaining that relationship, but they get to be home.
Yeah, and we'll talk a little bit more about technology and its role, and I think that's where absolutely that comes in for sure.
Yeah.
So thank you. Dr. Teplinsky, what are your thoughts?
Yeah, I mean, I think lots happening at ASCO this year. I mean, one of the big headlines that I'm sure everyone has seen and heard about is the GLP-1 data that has been all over the media, and there were a number of GLP-1 studies this year being presented at ASCO and surrounding the meeting as well, and really highlighting the fact that we can, we have a signal that GLP-1 medications can reduce cancer risk, and very excitingly, they can reduce the risk of cancer recurrence or progression to metastatic disease. And the challenge with this data is that it's observational. It's looking back at medical records. It's not prospective. And so I think we have enough to say that there's a signal, but we really need prospective data to now take us to the next direction and say, well, who's really going to benefit from the GLP-1? And one of the big challenges is we don't know how the GLP-1 medications are doing that. So is it through weight loss? Is it through impact on inflammation and metabolic health and insulin resistance? Is it a function of the GLP-1 medication itself? So there's a lot there that we're still exploring. And I always point out that it's important to know that the benefits of the GLP-1s, again, in these observational kind of retrospective studies, are in patients who qualified and met the current eligibility criteria for a GLP-1. So that is through weight, diabetes, and other weight-related conditions. And so patients are asking, well, should I go on a GLP-1? And I think we have to be really careful about how we interpret this data. But I'm excited for what the future brings, because there are a number of studies that are ongoing looking at GLP-1 in patients with breast cancer prospectively, and hopefully will answer some of that question. The OPTIMA trial was also very exciting, and this is a study that really looked to see can we de-escalate and pull back on chemotherapy in our premenopausal lymph node positive patients, or patients who have up to 9 positive lymph nodes, which we really haven't been able to do before. And without going in too much into the weeds of the study, but what they did was they used a molecular test called Prosigna, which is similar but different to what we currently use now more often in the clinic, like Oncotype or MammaPrint. And using Prosigna, they were able to show that patients who had a low score did not benefit from chemotherapy. So this is really exciting, because it will hopefully in the future allow us to pull back on chemotherapy in a much broader population in breast cancer, which has significant implications. One of the big things we have to keep in mind is that right now they still have very short-term follow-up. So we don't have long-term follow-up from this data. So we have to be mindful about really, understand the limitations of the data. And we should not substitute Oncotype or MammaPrint and to use that to use this study. So there's a number of research showing that there can be discordant results. So you can be low risk on one and high risk on the other. So if we're going to apply the OPTIMA study to our patients, really want to use the Prosigna test. So I think we're going to see that evolve, in the coming months to years as we get more data. And then lastly, there was a lot of information on metastatic breast cancer. And really we've seen in the metastatic breast cancer space an explosion of new drugs in the last few years, which has been very exciting. And now we're starting to really understand how to sequence them and how to use them, and how to think about antibody drug conjugates and some of our novel endocrine therapies that are coming out. So lots happening, lots of big data.
Thank you so much. I'm always curious, we went to this conference, I was there for a brief amount of time, and we come back. And the question I have is, how do these innovations get translated into actual care, and how long does that take? Because I assume that, especially with the pancreatic cancer drug that was discussed, patients hear this and they're coming in and asking for it. So how long does it usually take for these things to become real for patients?
I think it really depends. Something such as the RAS inhibitor for pancreatic cancer, that's very breakthrough. So that's getting incorporated very fast in terms of patients is aware, providers are aware. The caveat there is the medication itself is not available yet. So I think, yes, is ready to put into practice from both sides right away, but the drug itself is not available, right? So I think that's an access to care issue. There are few other great abstracts, such as like even for instance, Optima trial, right? Great, there is this component of patients with 5 to 9 axillary lymph node that might do not need chemotherapy, but how do not do our conventional oncotypes, MemmaPrint? Should we start doing that? Should we do that for all patients, or should we just reserve it for certain group of populations, such as patients who have 5 to 9 axillary lymph node? Although the data is not as for a long period of time compared to oncotype, MemmaPrint has a long follow-ups, and we know that those patients have a long-term follow-up showing that disease recurrence typically is low for those patients who are truly low score. So I think those are the nuances. We have so many different medications, so many different tests, but is it same test good for everybody, or do we need to individualize those tests? Sequencing of the medications, toxicity, which sequence would be better for this patient versus another patient? Same sequence might not be better. For lung cancer, for instance, EGFR medication, until 2-3 years ago, there was only one medication. I did not have to think much for any patient that walked in. Now I have up to 3 lines of treatment, and I need to think of sequencing in my mind. They're all approved in a first line, in a second line setting, but I wanted to make sure I get maximum mileage out of each medication, and I want to make sure that I sequence in such a way that I do not close the door, or I do not make patient performance status decline by doing something that they might not get to second or third line. So I think those are still real life challenges. We have a lot of medication, a lot of different tests, but how to utilize them for individual person, I think that's where we need more work done.
Absolutely. And I can imagine that, I just know the information that's shared in support groups, for example, that when people have the same disease diagnosis, and one person's getting one treatment and another person's getting another, or you didn't have as many chemo sessions as I did. I can imagine that it will prompt questions with patients when you use terms like de-escalation and things like that. Will patients understand that they're still getting the standard of care? Actually, it'll be better for them. I don't know what your thoughts are, Carolyn.
I think it's a sensitive conversation, and they need to have the data that's available. And I think that's not just, progression-free survival, overall survival, but also what symptoms the patient might have, or, those discussions about patient-reported outcomes on those clinical trials, and what they found, that this was not better than this, that this was, equal. But I do think it's a sensitive conversation, because sometimes I would feel to a patient, it might be like more treatment is better. And I think that's the discussion, is that more treatment may not be better for you in this instance, in this situation. So when they get to the support groups, they can discuss like that conversation was had, and care is so individualized now to biomarkers and to patient-specific characteristics that I think we need to take the time to have those sensitive conversations.
Dr. Teplinsky, was there anything that that you learned that challenges conventional thinking about treatment and care in any of the studies that you looked at?
Well, I think the Optima study, maybe not necessarily challenges, but, it's different than what we have done in the past. And it kind of really, you can say challenges this view that, if you have significant lymph node disease, if you're a premenopausal woman with lymph node disease, that you need hormone, that you need chemotherapy. And I think that we have been talking about this for a long time in terms of, is it the benefit of the chemotherapy in premenopausal women? Is it the benefit of ovarian suppression? And so we can see now that in the Optima study, the patients who are premenopausal were required to have ovarian suppression. So we can start to think that it's probably more the ovarian suppression and the estrogen deprivation that's benefiting here. And so I think that, as we get more and more data, right? Everything is kind of challenging. We're always growing as physicians and as clinicians, as nurses, as providers, as thinking about how do we fit that new data and what we know, and then how do we start changing and adapting? So I think a lot in the breast cancer space at ASCO this year, I mean, aside from that, there were some other studies, but mostly a lot of that was really reconciling a lot of these new medications and how we were going to think about them in sequencing and what comes first, then side effect management. And, there's a lot of excitement about SERDs, or selective estrogen receptor degraders, in early stage breast cancer, which we think may, in many cases replace tamoxifen and aromatase inhibitors. And we should hopefully see an approval for early stage SERDs soon at the end of the year. And so I think that's really going to challenge a lot of, what we do in day-to-day practice.
Thank you so much. I think let's move on to the next question that we have for our panelists. So oncology, we talked a little bit about how precise it's getting, this idea around precision medicine. It's personalized and patient-centered. But how do we move these innovations into people's lives? So for example, things like biomarker testing. We hear a lot about the importance of biomarker testing. And yet, I don't know how patients are accessing that, or if they're able to access, or what some of the challenges might be. So can I ask each one of you to kind of speak to that issue?
Yeah, I think for biomarker testing, I think the biggest challenges right now are not that they're not able to get it. I think physicians are very well aware, and nowadays, because of the precision medicine and every tumor, we have to test for multiple molecular markers. We all are asking for those tests, but I think there are delays in terms of just the way unfortunate the healthcare system is, in terms of getting biopsy to getting those testing. Those testings are usually, majority of time, are done by a third party. So accessing that tissue, sending the tissue to the third party, getting the reports back, then see the patient, starting the treatment. If it's an oral oncolytic, that takes another 1 or 2 weeks. So we need a streamlined process in terms of getting the access to the testing and access to those medication in a timely manner. I think getting those tests done is not a barrier, but I think getting those tests done in a timely manner and getting timely treated, I think that's the biggest barrier. And I think that's the barrier because of multiple different steps that has to be in place, right? Insurance approvals, getting our pathology department to send the tissues out. Unfortunately, every healthcare system also has strain in terms of workers, right? So they do not just send tissues out every day. And this is very, across all the health system, is very standardized, that they send the tissues out maybe 1 or 2 days in a week. So that's already delaying the things by 3 or 4 days. And by the time the tissue gets access to the third party. So those are the delays. And I think we need a better system in that regards. In terms of insurance, even this last week, I had a patient who was sitting there with the bill, and he's like, oh, my insurance company said they're not going to pay for this molecular testing because it's investigational. And I'm like, this is very standard of care. We need, and it's a lung cancer patient where we had to check for like 12 different mutations and ISC. And I'm like, this is very, very standard of care. Your insurance company, we will fight for it. And he's like, I don't want further testing. You're not going to do more testing without asking me. So those are the barriers, right? I think education to the patient, education, and majority of time, insurance company do come around, but I think those are the barriers that are in place and really delays things for us.
Well, and just to that, then you have the patient and their family members waiting. And in their mind, time is of the essence
Correct.
in many cases, right? So I think that, and then there's this fear that you're going to end up with costs that you can't afford that would ruin your family. So all of those are real concerns. I wish we had more time to talk about what some of the solutions might be. That might be another roundtable discussion. But yeah, thank you for sharing that. Dr. Toplinsky, what do you see as the challenges in trying to implement some of these innovations between academic medical centers and community-based medical centers? Because we want people to access care anywhere they need to get their care. But we know that not every care center has access to the resources that even you're describing, Dr.
Well, and I think we have to keep in mind that the majority of patients are treated in community centers. And so we have to make sure we're bridging this gap between what's happening in the academic setting and what's happening in the community. And, I think twofold, right? We have to understand what are the gaps in care in that regard. And if you have a clinician that is treating everything, treating multiple different cancers, it is impossible to keep up. I mean, the data this is not 10 years ago. I mean, the data is moving so rapidly that it is really hard to keep up with the nuances and these drugs and the tests and how to order them and all of that, right? So recognizing that this is really hard to do. I'm a big proponent of patient education. I do a lot of patient education online. And I think as we think about how do we get our clinicians, up to getting all that care, it's really important to empower patients also to ask for these tests, right? To see it online and to say, hey, I saw this, is this applicable for me? And so I think really, conversations, there's a lot of ways to bring some of the academic, the conferences to the community through things like podcasts and these events and things like that, really kind of the debrief that comes from the meeting. But I think it has to be twofold, both empowering patients to be educated and ask, as well as, how do we, again, bring that education to the community when someone is seeing multiple different cancer types.
Thank you. Carolyn, I'm just curious, what other barriers exist and what things have you seen that are maybe solutions or things that might work to bridge the gaps?
So one of the things that I saw was teleconsultation. So I think it's a lot of like what Dr. Toplinsky said about how we bring, the expertise to clinical teams as well. So there's teleconsultation for virtual tumor boards. So maybe there's areas that don't have that subspecialty expertise, and these tumor boards are virtual and should share that information. I think the VAs, National Virtual Tumor Boards in the VAs, is doing that. So it is a way to get the expertise to areas that may not have it. And I think the jarring statistic was 66% of rural counties in the country do not have an oncologist. So how we use like regional hubs to get that help out there to people that live far away from the care they have to access.
I think we forget that being on the coast.
I think we are very lucky that we don't have we have problems for sure, right? But I think we're very lucky that we don't have that problem of access and closest to care. We have so many options.
Thank you. I'm just curious, we're talking about technology. What is the role of AI in helping with I don't know if this is a positive conversation or a negative. I don't know. The new graduates are booing with AI is being discussed. We'll see what you guys say. But I'm just curious your thoughts.
There was a great discussion at ASCO, and I think I really like the way the AI is being incorporated into the medicine, especially for oncology. As we mentioned, I think it's very hard for a lot of the community docs who sees everything to keep up with every single detail, every single new abstract that comes out, or every single new practice changing guidelines that comes out. I think AI can help summarize the pathology. I think we can start with that. We are me and Dr. Toomey is going to be this pilot people also for staging. So AI is gonna not only summarize the pathology, but also stage it for us based on the imaging and the pathology and everything they can gather from the medical records. And I think eventually I want AI, those large language models like Open Evidence has ASCO guidelines, NCCN guidelines, they're incorporated in it. So I think after they recognize the disease staging, probably guide the physician in terms of next step of testing, if that's testings are done. So more like a pathways, but more like AI generated pathways. So instead of going through multiple different pages in the NCCN, you go from one page, then AI tells you those are the things next. Okay, pathologic molecular testing detected this. This is the approved treatment based on this abstract that was presented. So I think AI can be really helpful, narrow it down, gathering all that information from EMR and guide as in like a pathway for the physicians. I think that's how I will like large language model to be utilized in the EMR.
Dr. Toplinski, your thoughts on AI?
I mean, I actually spoke on this at ASCO and gave the discussion at that AI session. And so the part that there's kind of two things, right? And I think we've touched on a lot of the ways that AI can play a role in diagnostics, treatment, right on the clinical side. One of the things I may have missed, but there's some really exciting data about using AI to predict breast cancer risk and predict breast cancer risk kind of 5 years out, and that's going to be really helpful. And that's actually made it into the NCCN guidelines about using AI-based risk assessment. But the part that I talked about and I feel very strongly about is on the patient side. And, there was a paper presented at ASCO about they queried indexed web content. So what's on Google, what's on YouTube, about if patients are looking to get information about AI and cancer care, what is the information that they find online? And what they found was really not surprising but striking, was that only 15% of available resources actually talked about hallucination and misinformation risk with AI. And so one of the things that I think is really important, as AI is here, our patients are using AI, right? There's a scan result, putting it into ChatGPT. People are asking Claude or any other large language model to really help synthesize their medical care and put it all together and ask questions. And I will say I've seen some of those questions and I think they're good. It's asking the questions about the studies that we've talked about today. But I think it really raises a bigger question of who is responsible for this information, communicating the risks of AI. Because one of the things that we don't talk a lot about is what is the prompt that you give AI, right? Whether that's our trainees, whether that's our patients, whoever it is, or ourselves even, you have to be mindful of the prompt that you feed AI because that's what it's going to bring back to you. I saw a great analogy about this where if you go to the library and you want to research something, you would go to the library and look at all the books on that topic and synthesize it for yourself and put it together. With AI, it's basically like the librarian is standing at the door and saying, here are 3 books that I want you to read, instead of you doing all your research. And I think that's really appropriate and important because if we're saying, we have to remember how we feed AI, and our patients have to know that there is a risk for hallucination and misinformation. And who's responsible for that education? Who is responsible when there is AI and clinician conflict, which happens? And so I think that as we think about AI, there's a lot of excitement and there's been a lot of talk about how we can use AI in the clinical setting. And I really feel there's no answer to this right now, but I think we have to also shift and prioritize how our patients are using AI and what are the protections and the ramifications and the implications of that. So sorry, I don't have a good answer for you, but I want to raise that point because I think it's an important one.
Well, I know from our own work when the internet came out and people went to Google back in the day. Now it seems so old school, and they would Google and we would caution people about doing that without context, right? You have to have context. That's provided by your healthcare team. And so I do think advocacy organizations like ours have a role and responsibility in patient and family education to make sure we reemphasize that with people, because oftentimes they will come to us and start talking about their concerns and what they've done. So we do have an opportunity to intervene, but I do think it's going to take all of us, reinforcing that along the way. and making sure that it's an appropriate tool in context for people.
Yeah.
I'm curious, you know, as we're talking about the onslaught of innovation and technology and the volume that's coming at healthcare providers and ultimately patients and their families, what other support systems do you think are needed within healthcare to help patients and families? We've talked about some of that. Technology might be one, but is there anything else that you think would be valuable for institutions to consider having for patients, especially groups that might have specific needs like AYA patients and the like? Any thoughts on that?
I can chime in. You know, I think we have to understand, right, the healthcare system is almost at a crisis at this point. You know, people have 15 to 20-minute appointments. That is not enough time. And I think we really have to think about all of our other resources that are available. And especially as somebody who treats primarily AYA individuals and that younger early onset population, there are so many unique needs. And we have to think about, okay, who are the other people in our toolkit that we're bringing in, whether that is mental health therapists, sexual health therapists, endocrinologists, cardiologists, occupational therapists, pelvic floor PT. I mean, I can go on and on. But then at the same time, we have to be mindful of the cost of these services, the insurance coverage of these services, the time that it takes to utilize these. And I think it's really going to take all of us to, you know, help our patients. Our patients are living longer. We have more therapies that also come with more side effects. And so, you know, I love that we're talking about de-escalation where we can pull back, but at the same time, we've also escalated in a number of cases, and that increases the side effects. And so I think we really have to understand that our patients' lives revolve more than just the time they come to see us. And there's all this other context. And how do we recognize that? How do we talk about it and make sure that we are addressing that? You know, I had a patient who a couple of years ago who was, you know, missing appointments. And, you know, I'd asked, well, what's going on? And she said, well, I'm going to lose my job if I don't come. That, you know, and if I lose my job, I don't have health insurance. And so, right. And so I think we have to really understand the world that our patients live in, and that looks different for each person, to figure out how to best treat them and how to use all the resources that we have.
That's so powerful what you're saying. And I mean, I think that's part of the reason why here at Crossroads, we implemented our My Go-To support program, which is a direct to mobile, it's not an app, that allows us to provide seamless information and resources directly to a patient or caregiver's phone. But then we're also able to screen seamlessly for distress, for depression, and social needs, so that we can proactively deal with that within their lived environment. And I think that's key for us. You know, we're a community-based organization. You know, we want to make it seamless for patients. But the reality is they have to go to the cancer center. They have to go to the doctor. And when they have a lot of appointments and they're juggling work or parent care, child care issues, we see that burden every day on patients. And they're making choices that are not necessarily good for them long term. Carolyn, any thoughts on the conversation?
Yeah, I will say a couple of the digital like tools, apps. One was AI supported for glioblastoma, was a way to kind of stay connected. And the Dr. Binder, I believe, discussed this in a glioblastoma clinic. You've gotten a diagnosis, and now what happens when you're home in the evening and questions come up. And this particular application is meant to, you know, answer questions about diagnosis, about treatment. It provides some caregiver support. Caregivers and patients can use it. So I think more of that, like meeting the patient where they are and when they want that information, with information that's reliable, and it allows just for that extra layer of support, which you're used to because you deliver it here. Another was multiple myeloma and some symptom monitoring for fatigue, depression, quality of life with some digital tools. And then I just think from the basis of, you know, telehealth is, you know, we need telehealth, and we need those opportunities to, when we can, maybe pull back on clinic visits to, you know, keep oversight with the patient. But one of the presentations was about like that extended use of pembrolizumab over 6 weeks, and how do I, you know, maybe keep the patient out of clinic by having a telehealth visit at the 3-week time point, some home phlebotomy. I think that, speaks a little bit to disparity in access to care too, but it is the, opportunity to stay connected to the patient.
Yes, when I think about just general populations, and specifically, we were talking earlier about the AYA population. When you see how they AYA first, yeah, you might do that.
Adolescent and young adults.
And so you're talking about ages.
I think it's
40,
1939.
yeah, 40 and below, yeah, 40, 22.
Look at how they access care. They'll go to emergent care centers versus a primary care physician. They're looking for ease of access, and that may not be the best care. So I think the healthcare system has to look at patient populations and make sure that they have flexibility, whether through technology or other means, to be able to meet the needs of these patients long term.
And there has been a lot of different development. So I think myeloma, they had a new auto injector, the self injector medication that was presented at ASCO. So patients do not have to sit through the infusion center or come to the infusion. So I think that's the first in class. I forgot that. I don't know if it's one of the. No, it's not daratumumab. It's like a second or third line medication that is an auto injector that got approved based on that. And also self monitoring now, or home monitoring, is very popular. Same for myeloma. We have bite-specific, there's new therapies that required hospitalization, but that was actually one of the caveat. A lot of the community practices was having challenging to do that. So now they're coming up with the protocols, what to do without having patient to be hospitalized for a whole week. So a lot of the community setting and those kind of early data they were presented, opening the door for community practices to do those kind of treatment at the community center without having hospitalization. So patient goes home, there are home monitoring system. So if anything happens, patient can brought right back for management. So those are the new horizons, and those are the challenges that we should see some new ways of treating eventually. But there was at least few early data, n equal to probably 100 or less, but at least showing that benefit, and we can do this at the larger scale. So I think that was another thing that came out of ASCO as well, that we can do this at home without having missing patients from their family time or work time or whatever it might be, whatever other things they would like to do instead of staying in the hospital or infusion centers.
And we're going to talk next about patient access and what that looks like. And we had a conversation early on about oral therapies and oral parity, and just making sure that people have access, and financially that it's not a burden on them. But even taking medication, oral medications at home, monitoring that. I mean, when you're talking about home-based care, there's a lot of things that could go wrong in that for patients when they're not in a clinical setting. Any thoughts about that, Carolyn?
Well, I think that's where the use of patient-reported outcomes and screening comes into play, where the patients, can be pushed some of these tools, and the clinician grading doesn't always match the patient grading, and it doesn't always indicate the level of burden of a symptom for that patient, their functional status based on that symptom. So I think it is a way for clinicians to track like the trends, how bothersome something is, when a toxicity is becoming unacceptable, and reach out proactively. But I think those that patient-reported outcomes was also a huge part of many of the presentations that was exciting to know about. Like one of the advocates said, I think the primary endpoints in clinical trials, overall survival, progression-free survival, that is wonderful. And she said, I always think that the patient-reported outcomes should be the co-primary endpoint, not a secondary endpoint, like how I can tolerate this, how I'm going to tolerate this treatment too. So a patient gets the whole, picture about what this drug can do and how they might feel.
Thank you. So, we were talking a lot about innovation, and And what do we think, or what are your thoughts on the biggest barriers preventing advances in care reaching patients? So we talked for a second about cost. You know, what other barriers exist, Dr. Patel?
Before I answer that, isatuximab is the medication for it is for multiple myeloma, another anti-CD38. Um, so what are the
barriers that you're seeing in terms of people being able to access this type of care?
Yeah, I think definitely there are many different disparities that we have seen. I think we talked about some of them. I think for younger population, it's definitely juggling the childcare, parent care, work, right? So I think those are definitely one of the major ones. Other than that, I think clinical trial availability, right? So there are trials that might not be available around the community setting they are in. It might require them to travel somewhere 1 hour away, which is not feasible for them. I have patient who had certain disease and there was a trial that was open in New York or in UPenn, like in Pennsylvania, but they're like, okay, logistically it doesn't work, right? So they're like, oh, I cannot go there. I do not have support for somebody to take me there, or I cannot stay there 2-3 hours. There is nobody to take me or drive me there. So there are a lot of those logistic issues. So that really have a barrier in terms of getting into those newer clinical trials or newer drugs. Other than that, I think financial toxicity, a lot of out-of-pocket costs, high deductibles. So those are also another great barrier. Patients are choosing, unfortunately, they have to choose some financial versus getting their care, which is very unfortunate.
With health insurance.
With health insurances, yeah, with health insurance.
Don't have health insurance.
Correct.
You've got insurance and you can't.
And you cannot pay for care.
I think that's, you know, the things that we've been talking a lot about, and the thing that we're seeing is just how insurance is starting to impose, you know, utilization management and all of these steps that delay access to care. From our vantage point, it's what is the effect on the patient and the patient's worrying and distressed and concerned that their cancer is advancing while all this is happening. But that's starting to increase. And so I think, you know, that's a challenging thing for patients to navigate in general.
Yeah. And I think just going back to that AI, I hope insurance company, if they're willing to do it, they can utilize this AI system on their back end as well to do a quick utilization review to get faster approvals of all medications, imaging, whatever is needed to minimize that time from diagnosis to start the treatment. If they really want to do it, I think the AI can really help them get that done.
Or it'd be a battle between your AI and their AI.
There, that's true too.
Well, you know, what'll be interesting is if they're provided access to that, will they take it? Because that'll tell you a lot about what's driving their business model. Dr. Toplinski, any thoughts on this conversation that you'd like to share?
No, I mean, I think a lot has been already said. I don't have anything else to add. I think just recognizing the barriers and starting to think about, you know, what are the small ways we can start to combat them. I will say, I mean, I love the work that you do and other amazing nonprofits, right? And really helping attack some of these barriers to helping make those connections and help with access. But it's going to take all of us to work through those.
While I was there was a lot of discussion around things like the Medicaid work rules that are coming out, changes in insurance for patients. And I think, you know, it is our responsibility to continue to elevate the patient voice and to advocate for positive changes in healthcare. So thank you.
May I say something though that I think is important and perhaps like a positive is financial toxicity screening is happening, right? There are screenings that are happening, and I think we're at that point of like, we know that there's a problem, we're going to start screening for the problem, and then we need a host of solutions for that problem. But I think we've seen social drivers of health, that screening is happening. Like Do patients have transportation? Do they have food insecurity? Like, we know those things are happening, like the screening to understand the patient experience. And now it's more about like, okay, and then we screen for that and we know there's a problem, and what are all of the potential solutions? And I agree, organizations like yours who can walk people through those particular hurdles are, needed and excellent. And I'm glad to be here and hoping everybody is referring.
Well, I think we're also trying to advocate at the national level and with leaders who can affect policy in
Right.
Washington and at the state level, because I think the challenge is I don't know that they understand what's happening to their
Right.
constituents. And there's this tsunami headed our way, and we want to make sure that people have access to care. So some of these policies do have to change. So I think at this point we'd like to open it up to questions from everyone. So we have some folks on Zoom if you want to type into chat, but we're also happy to take any questions from anyone in the room here. Just raise your hand. Yeah.
So in the conversation around AI's utilization, the promise of this is that between chart-in and case conference review and doing research, we're supposed to save time, right? So if you save 20 minutes a day, administration is going to want you to see another patient, but patients want you to spend more time with them. And your mental health says you should probably go home and spend time with your family. Which one's going to win? And how do you advocate for yourself?
So we started AI in our office. And I started it. So the least computer savvy person.
She admitted that, yeah.
And it was supposed to save me 100 minutes a week. And I thought that wasn't very much. The average physician for a full day of seeing patients, nurse practitioner, physician, providers, right, spend about 4 hours documenting. So if I had 3 full days, that's another day and a half that I'm documenting. This thing came along, I said, oh, pulling this in. Now, is it saving me time? A little bit, not a lot. It's not that 100 minutes even yet, but it's documenting better than I can because it has more time. Makes it a minute or two. And when I went to San Antonio this year to the breast meeting, I went into the cases, and I didn't realize there was ambient AI in the room. And so what I found was, people get up and give their tough cases, and the humans give the recommendations. And then a minute or two later, the AI gave its recommendations, and they matched. They matched really very well. The differences were the humans were faster because they knew what they do, and the AI was more comprehensive. They didn't leave anything out. It wasn't a fault of the humans. They just didn't happen to mention the genetic testing, for example. So I'm very excited. And I hope it gives me more time at home or out on the trails or wherever I want to go. But we're very excited. We're very excited. So we got everybody in the office, right? Using it. And we use it for thank you for that.
Do you want to take a mic?
I don't think of my other patients, but I find it very important.
We're gonna give you a mic that's on the call for you. And we'll pass it around and then go to the question.
Thank you. I have used it now at where I work. I work at Sloan Kettering with breast cancer patients, and maybe because I talk a lot, the patients talk a lot. I find it very wordy, so I do use AI. Not all the doctors like the AI because they would look at our notes before their visits, et cetera. But so I think it's definitely helpful. I just have to figure out how it's really going to work for our population and the people that I work with. We did have personal training. I know how to do it. I wasn't that computer savvy, but it's not hard. You have your iPhone, but sometimes patients don't want you to do it either. They say, no, I do not want you to record this meeting. So sometimes patients are reluctant, and we have to abide by that. We need to have their informed consent. That's important.
just want to thank you for inviting us and also for painting the picture of the community oncologist. That I think it's really exciting to hear about all the technology and the bispecifics and all the very exciting technology. But as a nurse practitioner, I always wonder about the access and by the caregiver. You know, this therapy might be great, but you don't have anyone to bring you there or to help manage your toxicity, so we cannot offer it to you. So I do think with this technology, we're having like a tale of two cities a little bit. And I think it's important for all of us in this kind of forums to acknowledge that and work towards bringing equity to these patients.
Well, and we're at the beginning stages. Hopefully Dr. Chimmy's training. So I'm going to ask just a couple of closing questions for all of you. And I think, you know, first of all, is there one message that came out of ASCO that you believe that every oncology professional should understand?
I think a few things. First is precision medicine. So every treatment nowadays should be driven accordingly to the biology. We saw multiple, both side of the stories, right? So if you take, for instance, for even precision medicine, for circulating tumor DNA, there were some trials that showed early intervention is better. So for breast, I think Serena-6 trial showed as soon as you detect the ESR1 mutation, you start them on the targeted therapies better. Same with the lung cancer. We saw that for people who have EGFR mutation, and if within 3 weeks, if they're not clearing their circulating tumor DNA, we need to escalate the treatment. So we saw that. And on the other side, we also saw how certain target like TIGIT, which was one of the great class of drugs, and we thought it would be very exciting, but there was a negative trial for lung cancer. So I think we are moving towards more and more precision medicine. Always more is not better. I learned that as well from this ASCO, because there was 2 lung trial that they added something on top of immunotherapy or added immunotherapy ahead of for small cell lung cancer, and those trials were negative. So more is not better. Same with, I think, Destiny trial for TDXD plus pertuzumab showed great benefit, but then toxicity was much higher, 12% of interstitial pneumonitis. So I think having all this data, escalate, de-escalate, adding more, you get better benefit, but then toxicity, I think, is a lot, and we need to really, as I said, hopefully AI will also help us which patients are higher in terms of developing certain toxicity to avoid certain combination. So I think those are the challenges that remain, but I think overall we are having a lot of good medications. What I want to see, and hopefully we will see in the future, is how to deliver a better system of care instead of how to deliver better medications, how to deliver as a whole system of oncology care. And that's what I want to see going forward. But I think that's what I will say.
Thank you. Karen.
That was a great answer.
Yeah, good answer.
I was kind of taken aback by the amount of data to kind of digest there, but also thinking about like novel toxicity and symptom management. So now we have novel agents being combined with other novel agents, and this is kind of going to be the future, but what does that mean for symptom monitoring and toxicity? So those new novel side effects we're seeing, like ocular toxicities and things we might not have managed as much,
Yes.
right? And I think there's going to be a lot to learn and take in and digest and be able to, you know, help our patients from there. But it's exciting innovation.
And I think if we can help patients be able to participate more actively, not be afraid to share symptoms that they're having, they might be afraid. You know, we see patients who are afraid to tell the doctor
Right.
what's happening because they're afraid they're going to be taken off of their treatment.
That was distinctly said in a session, the fear of being honest about symptoms, and that clinicians at the start should say, just because you have some symptoms does not necessarily mean I am going to take that drug away or reduce the drug. We need to talk about it, but we have to talk about it early. It's a great point.
Yeah, I think we have to work to build trust and openness, or we won't find out what we
Right.
need to know.
Right.
Dr. Toplinsky, what are your thoughts?
I agree with everything that's been said, and I want to echo that as we see new medications and that come with these unique side effects that we haven't seen before, like ocular toxicity, or as we're using bispecifics, and those come with new toxicities. I think there is a fear of using the drugs. Sometimes people are comfortable with, well, I know I use this and it works and I know how to manage the side effects. And we saw that when we started using trastuzumab deruxtecan and that interstitial lung disease, and we were all so nervous about it because when the drug is new, you only have a few patients that have been on it. And so you think about those side effects, and those side effects always stay with you, and there's fear. And so I think one of my takeaway points and some things to talk about is really the fact that we're all learning together. And I tell my patients all the time, I say, this drug is new. We're learning from each other, right? You're telling me these side effects. I want to hear them so that we can learn how to take care of them, how to optimize them, when to dose reduce if we need to. And I think that's a big thing about, there's a lot of fear of dose reduction. And a lot of the new drugs, we've seen really good data that you can safely dose reduce without compromising efficacy. And so I think as we think about how do we put all this new information together and into practice, it's a lot. And I think side effect management, both short-term and long-term side effect management, is scary. But I think just taking it one side effect at a time and working with our pharmaceutical partners have a lot of information. And so when a drug is new, if I see a side effect that hasn't been reported, I will call them and say, what do we know about this? What have you seen? It helps them add to their data. But they can give us information. And I was doing that a lot with, the early days of TDXD when we were managing ILD, or even with the immunotherapy, back in the day. So I think not to work together to manage those side effects is really important.
Thank you. And I think as much as we feel overwhelmed by everything coming at us, the patient and the caregivers are overwhelmed as well. And so we have to make sure that, to your point, we're learning together and that they feel part of this journey.
Yeah.
So final question. So if we were here 5 years from now, what progress would you like to have seen where in terms of cancer treatment? As you start to think about what's ahead of us, what would you like to be talking about 5 years from now?
I think I want to see and hope we have learned what are the risk factors and the drivers in the trends of younger cancer diagnosis, so that can inform what the screening should be. I think we need to know more of why this is happening, so that we can put some plans into place to catch it earlier.
Was there anything that came out of ASCO that's shedding some light on what's happening?
So Gallery test, which is a pan-tumor screening test, which is also another lot of news, and a lot of patients ask about it. It did not meet its primary endpoint, although still reported out 20% reduction in a stage 4 diagnosis, and also 21 to 25% reduction in an emergency room diagnosis. So emergency room diagnosis are the patients who are very symptomatic, gets diagnosed in the ER, usually has a poor prognosis, a poor outcome. So 21 to 25% reduction in that, 20% reduction in a stage 4 cases. So cases where cases were detected earlier in an earlier stage. What does this mean for general population? Do we do it for everyone? If we find something, what do we do? And I think that will, in a 5 to 10 years, I think that's what I want to learn, how to utilize that early molecular testing to either cure patients earlier or treat them in an early stage and cure them that way and decrease the advanced stages. And I think that, even though that trial did not meet its criteria because of the statistical significance, the way it was designed, but I think it has a lot of potential over time.
And so I've had this conversation with a large insurer in the country. And, we used to talk about previvorship, people who are at risk of developing cancer due to job exposure in their community or genetic risk. And there's a lot of worry that comes with that. There's a lot of patient education and support that's required. We've moved the dial forward a bit, where now we might be able to tell you that you have cells in your body that are cancerous, even if you are maybe not visibly dealing with a cancer tumor. What are you then? To the insurer, to the healthcare system, knowing that information, what's the risk of knowing that information for life insurance, health insurance? And so I think the challenge is just like the country is dealing with. Technology is moving so fast that we don't really understand the full implications of what's happening in real time. And we won't really know for a while. Right. But we've now created a new class of patient that may be diagnosed before they're actually diagnosed. And we don't know what to do with them necessarily. Right. Dr. Toplinsky, 5 years from now, when you're sitting with us, what would you like to see happen in cancer?
Well, I guess we'll be sitting together in 2031. I think one of the big things, and I think we touched on it a little bit, is, the role of circulating tumor DNA and really better understanding who is at risk for recurrence, using circulating tumor DNA, again, this concept of MRD or minimal residual disease or molecular residual disease, of can you use that to predict, we know it's a prognostic factor now, but can we use that to predict where we can pull back on treatment, where we can escalate? We're starting to see this very early in triple negative breast cancer, but we're not yet at a point where we can clinically act on it. So I would love to see data that really looks at that from the very beginning and intervenes and de-escalates and escalates where appropriate. And then I agree with what's been said about, early onset cancer. And, we are seeing a rise in patients diagnosed with multiple cancers before the age of 50, and really starting to understand why that's happening. What are the lifestyle, the environmental exposures that are playing a role, and how can we begin to start to understand and modify those to lower risk? And along with that is going to be that focused, personalized screening, understanding that as we see younger cancer, our current models for screening may no longer be appropriate or may have to adapt for individual people based on risk. So all of those things.
Well, and there's a conversation that we've been having here because, I've been doing this 14 years this year, and I have never seen so many younger patients being diagnosed with advanced and multiple cancers.
Unfortunately.
And you do pause and say to yourself, why is that happening? Like, am I seeing this? Are we seeing this? And we are seeing it every day. So I would like to understand, hopefully, what's driving some of that so that we can get to people earlier and make sure that they get care earlier. So let me just check to make sure there's no questions on Zoom before we end. Okay. So I want to thank all of you for coming out on this rainy night, because some people weren't so brave to come out. Paul at the camp, I'm like, Jersey, rain. But apparently some of us do. I'm glad tonight. This is a first of many conversations we hope to have, because I believe it's important to bring everybody together. We are going to figure out how to package this as education for patients and for advocacy. And I think it's really important. We do have pharma partners here, and I hope hearing from the doctors who are trying to administer these therapies in real situations and some of the challenges that they're having to deal with, hopefully will help inform your work as well. So I thank you. I want to thank everybody on Zoom, and we look forward to seeing you again soon on a different topic. Thank you very much.
Thank you so much.